Hi everyone, welcome to a new topic for Pathophysiology 2, where we look at the digestive system and disorders that are related to it. In today's recording, I'm going to be talking about herniations as well as motility disorders. Let's spend a couple of minutes reviewing normal anatomy, specifically looking at the gastrointestinal tract. Remember that when we eat food, it's going to move into the back of our throat, which is our pharynx, and be swallowed as a bolus down our esophagus, where it will reach our stomach. It will pass through, in this process, two main sphincters. We have an upper esophageal sphincter and a lower esophageal sphincter. So when food moves through and pushes through that upper esophageal sphincter, it's going to move in a downward direction through the lower esophageal sphincter and into the stomach. It's at the level of the stomach where foods can be mixed and churned and mechanically and chemically digested. Very little absorption occurs at the level of the stomach. Then food will move through what's called the pyloric sphincter from the stomach to the small intestine. Food will then move into the small intestine, the first part being the duodenum, where it moves through, and then we're going to be absorbing food into our bloodstream. Then it moves into the jejunum, and then it moves through into the ileum, which is the final part of the small intestine, where it will then enter the first part of the large intestine, which is the cecum. So here is the cecum. Off the cecum, we have the appendix. And then food will move up through the ascending colon. Colon refers to large intestine. And then across the transverse colon. Then down the descending colon. And then it will enter the sigmoid colon, which you can't see it here, but it has a bit of an S shape to it. Then it will end up in the rectum. And then it will be eliminated from the body through the process of defecation, which is elimination of food from the rectum through the anus. Looking at some different layers that make up our digestive tract. So we're looking again at normal anatomy. You can see the serosa, submucosa, mucosa, and muscularis layer. We're going to have a look at them from most external to most internal. The serosa is the most external layer, and it's the serosal layer that will connect with other serosa membranes throughout our abdomen, where the serosa will be very continuous throughout our abdomen, making up what you might remember as the peritoneum. Moving a little bit more internal now, we've got the muscularis layer, and these are smooth muscle that when they contract will encourage the normal forward movement of food through our digestive tract. And also, depending on the area that this is found within the gastrointestinal tract, these muscles will also encourage the breakdown of food. You might recall peristalsis is that forward movement of food, and segmentation is where the muscles contract to break food up. So that is the muscularis layer. We also have the submucosal layer. You can see some glands that are present here that will release their contents into the lumen of the digestive tract. The mucosa is going to be the layer where food comes into contact with and will be absorbed within the mucosa. If we look here at these structures, these are called villi. And villi are these projections, finger-like projections that are seen as part of, most definitely within the small intestine where absorption is occurring the most, but nutrients can be absorbed all along these different projections, which really increases the surface area for absorption instead of having it just a straight line where food can only be absorbed along that layer. It can be absorbed anywhere along these projections. And then to make the surface area even larger, we have these microvilli that are present. You can't see them on here, but they're present on these villi, which further increase the surface area because you can absorb food or nutrients all along these microvilli as well as all along the villi that they're found on. So this is a general overview. The exact details of the layers are going to vary depending on which area we are looking at within the digestive tract. And then finally, the accessory organs of digestion. These are organs that food's not coming into direct contact with, but they're considered an accessory, so they still help with digestion, and that would be the liver, the gallbladder, and the pancreas. I'm going to give you a brief overview of each and their involvement with digestion. The pancreas, you may recall, produces digestive enzymes, making it an exocrine organ. And these digestive enzymes get released directly through ducts into the upper part of the small intestine to help break down nutrients even further so that they're ready for us to absorb into our bloodstream. The pancreas also produces hormones such as insulin and glucagon, which are important in maintaining glucose levels in our blood. So that makes it also an endocrine organ. The liver is where once we absorb nutrients into blood, it's going to travel to the liver first, where it's going to be detoxified. So that's one of the main functions of the liver, is to detoxify our blood. It's also going to metabolize some of the nutrients that pass through it. It's also going to be a reservoir where glucose is stored if we need more of it. And then the byproducts or the waste products from the detoxification process will be sent to the gallbladder, where they will ultimately be released in order to get rid of the waste. So released into the small intestine through these ducts to get rid of the waste. And then also the gallbladder contains substances that help break down fats. So that was an overview of our digestive system. Some of the detail is included here. So this is a review of both mechanical and chemical digestion. And you can take a read through this on your own to remind yourself of some of the important steps that occur as food passes through our system. Okay, let's talk a little bit about the esophagus and a condition that can occur. First of all, where is the esophagus located? So if you feel the front of your neck, you'll be able to palpate the rings that make up the cartilaginous rings that make up your trachea. Just posterior to that is your esophagus, which is, we know, where food, when it is swallowed, goes into the esophagus. And so it starts then from the back of your throat, the pharynx, all the way down to your stomach. So it's also located here near our heart and our lungs. The first condition is called a fistula. A fistula, you can make note of, is an abnormal connection that should not be present. And fistulas can form really all throughout the body, but we're going to talk about a specific one relating to the esophagus. Okay, so it's an abnormal connection which should not normally be present. So if we speak about an esophageal fistula, it's really an esophageal tracheal fistula. And so the reason that the esophagus is more likely to form an abnormal connection or fistula with the trachea is because of their very close proximity. And I refer to it as an esophageal tracheal fistula, but you may also read it as a tracheoesophageal fistula. In any case, there's an abnormal connection between these two organs because they are so closely found together. On this slide, we're going to have a look at what's called esophageal atresia, which is referring to image A here. And then we're going to look at 4 different scenarios with tracheoesophageal fistulas. Starting with esophageal atresia. Atresia is a condition in which there is an orifice or a passage within the body that's closed or absent. And what you can see here, this is normally supposed to be the esophagus, which would connect to the stomach, and then we have the trachea here. But in this case, this baby was born with a blunt end here. And because of this, it would make sense to you that they're going to be unable to consume any form of food or liquid because it has nowhere to go. So there is no connection then between the esophagus and the stomach. So if a baby's born with this condition, then they're not able to get food or liquid into the stomach. This can lead to malnourishment very quickly. Food is either going to be vomited up or it's going to be accidentally aspirated into the trachea and therefore into the lungs. The next examples that we'll look at are all going to be pertaining to the tracheal, esophageal, or esophageal tracheal fistulas, so an abnormal connection between these structures. In this first example, the esophagus ends blindly and then a fistula connects part of the esophagus to the trachea, which you can see occurring here. And so when food is consumed, it's going to then enter the trachea and end up in the lungs. And this can lead to conditions such as pneumonia and pneumonitis, which is just inflammation of the lungs, but it can also lead to malnourishment and starvation because food is not getting into the stomach. And we know that it's not until we begin at the level of the small intestine with the duodenum where food or nutrients are going to be absorbed into the blood. In example C, we have a bit of a combination with this unusual condition where, first of all, we have that esophageal atresia occurring, but we also have a fistula connecting the distal esophagus, so here, to the trachea. But of course, the proximal and the distal esophagus need to be connected in order for food to get to the stomach, and so they're not connected. And so what we end up seeing occurring is that acid from within the stomach is going to back up into the trachea. And in addition, air is going to enter the stomach. This would also lead to cases of starvation for obvious reasons and malnourishment. Now in image D and E, what we can see occurring is that there is a connection between the esophagus and the trachea. So there's the fistula present, but the esophagus is still connected to the stomach. So in these cases, the baby can still get food in, but there is a much higher chance of acid moving up into the lungs and liquid moving up into the lungs. Same with this here, liquids moving into the lungs. And there's also the risk of fluid and food entering into the lungs this way as well as air entering the stomach. So you can see the concerns that exist here and how it could be problematic for survival for the baby. Even something as simple as saliva entering the lungs when they shouldn't be can be life-threatening. And these can usually be successfully corrected with surgery, but it needs to be treated early on, but it's usually identified quite quickly. And there's usually a genetic cause associated with esophageal atresia and tracheoesophageal fistulas. We're going to have a look at some fairly common gastroesophageal disorders. Gastro is referring to the stomach. And the first one is dysphagia. And I really want you to note the G here, because there are different conditions like dysphagia with an S that can mean something different. Dysphagia with a G refers to difficulty in swallowing. So this can be mechanical, meaning that there's some sort of obstruction that prevents a person from being able to swallow properly, or it can be functional. So maybe part of the muscles that permit swallowing, maybe there's a problem with innervation or nerve supply to that muscle, and so the muscles can't function or operate properly. Achalasia, this has to do that A usually means lack of when it's there as a prefix. This refers to no movement of food down the esophagus and into the stomach. And the cause of this is going to be loss of nerve supply. So denervation to the esophagus causing lack of peristalsis, which is that forward movement of food through our gastrointestinal tract. So food will sort of pool because it can't move forward without those muscles contracting it and pushing it down the esophagus. But eventually there will be some movement just because of gravity alone, bringing that food through more down towards the distal part of the esophagus. But the problem is with that is it can start to build up and cause dilation as it's backing up into the esophagus at this end, and it can grow to expand quite large, which is uncomfortable and dangerous because it can cause damage to structures in the area, including that lower esophageal sphincter that I spoke about when I talked about normal anatomy. Gastroesophageal reflux disease, or GERD for short, is a digestive disorder that specifically affects the lower esophageal sphincter. And so what we see with this condition is this lower esophageal sphincter is not working properly in order to prevent the backward movement of food. Remember, we want food moving in a forward direction or downward, but still one direction. So the stomach is very acidic, and normally this lower esophageal sphincter would remain closed to prevent the backward movement of food and acidic substances. But with GERD, this esophageal sphincter is not working properly, and it's instead permitting that backward movement of the gastric acid or acidic contents from the stomach into the esophagus. And this has many different causes, but overall it has to do with inappropriate relaxation of that lower esophageal sphincter. So it's remaining relaxed when it shouldn't. So in terms of definition, just to be more concise there for you, is with GERD, it's a digestive disorder, affects that lower esophageal sphincter, permitting the movement of acidic substances upward through that sphincter to the esophagus, which can cause pain. People will describe it as heartburn, and the reason for that is because our heart is located here, and the acidic contents are burning and activating pain receptors within our esophagus, and it feels like it's at the level of our heart. Next up is a hiatal hernia. With a hiatal hernia, this is where part of the stomach, we're going to look at this soon, moves up through the diaphragm. So normally the diaphragm, we can just see it here if we look closely. This is where part of the stomach will herniate and move above the diaphragm, but we will see this again shortly. We'll look at the different types of hernias in today's lecture, but in terms of causes, there are many different potential causes. It could be congenital. For example, you could have somebody with an esophagus that's too short that ends up pulling the stomach up higher than it should be. Or if for some reason there is persistent, intense pressure, it can cause that stomach to herniate to an area where it's under lower pressure. Now, how could intense pressure start up? Well, there's a lot of different reasons. Somebody could be coughing very, very hard, maybe persistent vomiting, lifting heavy objects. Anything that ends up increasing your intra-abdominal pressure can cause certain organs to move from an area where they're under high pressure to an area of lower pressure. And I did want to mention, because I didn't note it earlier, that when we talked about achalasia and how food will have a difficult time moving through the esophagus because of the denervation, and that it can build up towards the bottom, you can see that ballooning out occurring here just before that lower esophageal sphincter. I'd like to remind you of the pH scale before we move on to our next topic. Remember that a pH scale is a measure of the degree of acidity or alkalinity of a solution, and it's measured on a scale called the pH scale, ranging from 0 to 14, with the midpoint at neutral being 7. And so with a neutral pH of 7, we're looking at a solution that's neither acidic nor alkaline. Numbers below 7 indicate that there is acidity, and then it's more acidic the lower the number is. And then numbers above 7 are going to be getting more alkaline, or we could say more basic. And this also has to do, acidity has to do with the number of hydrogen ions that are found in a solution. So what you should know is that the more hydrogen ions, the more acidic the solution, the less hydrogen ions, the less acidic. And most of our body systems will operate in order to maintain homeostasis within a very narrow range. And even though you might not think there's a big difference between 6 and 7, there is a huge difference. The pH scale is logarithmic, which means that moving on throughout the scale is going to result in a 10-fold increase in the degree of either alkalinity or acidity. The next couple of slides we'll be looking a little bit more at GERD and the hiatal hernias. But first is a reminder of a few important details. One is we know that that lower esophageal sphincter found here, its function is going to be really separating food from your stomach and your esophagus, encouraging that forward movement of food. The normal pH of the stomach falls between 1 and 4, so it is acidic. And it's going to vary in how acidic it is depending on what food is present. So it's going to be between 1 and 4. The normal pH of the esophagus, however, is 7.3 to 7.45, so that makes it neutral. So you could see why the esophagus won't be able to handle for very long the acidity that comes from the stomach. Now, the relative location of the lower esophageal sphincter to the diaphragm is very important. Here we can see the lower esophageal sphincter, or you can't see the sphincter, but we know its approximate location, joining the esophagus to the stomach. And here's the diaphragm. You can clearly see in this image that the lower esophageal sphincter is below the diaphragm. Or we could say that the diaphragm is above the lower esophageal sphincter. So that's important for when we look at our next topic. This is a video that you can watch on your own, showing you a little bit about GERD and what it would look like with stomach contents moving back up into the esophagus. We'll see this soon, but just to give you an introduction, here is the esophagus, and this is the stomach. We can see that there's an enlarged part here, so this is part of the stomach that's herniated above the diaphragm, and we can't see the lower esophageal sphincter, but it would be approximately here, so now it's above the diaphragm. And what we can see with the movement of stomach contents, which in this case would probably be very chronic, is that we have the formation of ulcers because this esophageal tissue is not designed to be exposed to acid. So now we're going to look at hiatal hernias, and then on the next slide we're going to look at some of the negative effects of hiatal hernias and GERD, because those with a hiatal hernia are more likely to experience the signs and symptoms of GERD. So what is a hiatal hernia? So a hernia is just the movement of something from where it's supposed to be to somewhere else, usually moving from an area where it's under higher pressure to lower pressure. Hiatal refers to opening, so this is a movement into another opening. And specifically in this case, the opening is the hiatus, and the hiatus is the area where the esophagus and other structures pass through into the abdomen. So if we look here, there would be an opening right here that would allow the passage of the esophagus and other structures down into the abdominal cavity. So this opening is called the hiatus. So what is a hiatal hernia then? It is a type of diaphragmatic hernia because it's occurring through that hiatus in the diaphragm, where we're getting protrusion or herniation of the upper part of the stomach through the diaphragm or through that hiatus. So normally the stomach, of course, should be below. Here's the the esophagus moving through the diaphragm here, and this is normal, and see how the stomach is found below. But with these hernias, as it's moving up through that hiatus, really sort of sliding into the thorax, which leads me to the first type, which is a sliding hernia. You should make note that this is the most common type. Somewhere between 90 and 95% of hiatal hernias are sliding hiatal hernias. And what happens here is the proximal portion of the stomach is going to move into the thorax area through the hiatus that's present here. Now, while the individual if they're lying supine, so lying on their back, the lower part of the esophagus and the stomach get pulled, they sort of slide into the thorax, or they get pulled into the thorax because of changes in pressure. And then when they sit up, it sort of slides back down. So they lie down, it moves up, they sit up, it slides back to where it's supposed to be because of gravity. So this will be exacerbated by really anything that increases intra-abdominal pressure. And this is associated with GERD because the normal resting pressure of that lower esophageal sphincter, so this is the sphincter here, the junction between the stomach and the esophagus, gastroesophageal junction is where our lower esophageal sphincter is located. The normal pressure is going to be decreased, and it's not going to be as tight as it should be because of this sliding hernia. So it's going to cause stomach contents to be more easily able to move into the esophagus, which will cause pain and discomfort and eventually can lead to the development of ulcers. So we can see this hernia here where it's protruded part of the stomach then above the diaphragm. I really want you to make note of where the lower esophageal sphincter is, so that junction between the stomach and the esophagus, the gastroesophageal junction. Here you can note that it is now where it isn't supposed to be. It is above the diaphragm or superior to the diaphragm, and that's why it contributes to the development of GERD. Now with a paraesophageal hiatal hernia, this is also called a rolling hernia. And what happens is part of the stomach, so part of this really greater curvature area of the stomach is going to herniate superior to the diaphragm. You can see that occurring here. And so it almost looks like it's part of the stomach is lined up beside the esophagus, hence the name paraesophageal hiatal hernia. Now, note that the lower esophageal sphincter is still below the diaphragm. It's still inferior to the diaphragm. And so the experience of GERD is less likely to happen with this condition compared to what we just spoke about. Now, that doesn't mean this person's in the clear, of course. You could probably appreciate why this part of the stomach could experience almost strangulation, where there's a reduction in mucosal blood flow because of this compression, and it can cause damage, it can cause ulcers, so many other conditions can occur even though they may not be experiencing GERD. And then with a mixed hiatal hernia, this is a mix of your sliding and your rolling, or your sliding and your paraesophageal, where we have the lower esophageal sphincter now located superior to the diaphragm. So GERD is likely, and strangulation of this part of the stomach, which would be this part here, is also going to be a problem. So what we have here is, in this first example, we have this part of the stomach that just slides above the diaphragm. And then with these two conditions, we have more of this part herniating up beside the esophagus. So instead of it all sort of sliding in this direction, like what we see with this hernia, this pinches within here and aligns itself with the esophagus. We're going to look now at the effects of hiatal hernias and GERD, which are more common for a variety of reasons to occur with age, but can also coincide with a variety of different other conditions. But what's seen with people that have GERD is that there's going to be regurgitation of chyme. Remember, chyme is the food that's been mixed up with acid and different enzymes within your stomach. As that chyme regurgitates or moves upward into the esophagus, what we then see is the symptom of postprandial heartburn. So the person will report that after they eat a meal, that's postprandial, they get heartburn. It's considered non-cardiac because we know it's not related to the heart. It just feels like it is because of the area that burning is taking place in your esophagus. Reflux esophagitis can occur, and this is where the esophagus, because of what we're experiencing with the regurgitation, can become inflamed. So itis referring to inflammation. Over time, inflammation that is chronic can lead to ulcers, and these ulcers can bleed depending on how badly the tissue is eroded and whether or not the blood vessels are affected. And this is going to be quite painful. So what we've seen then is that, or what we've learned is that acid is going to be getting into the esophagus, and the esophageal tissue is not designed to be exposed to this acid. So the acid causes erosion of this epithelial tissue, and this can lead to ulcers, as I mentioned, and bleeding, but it can also lead over time to scar formation. And scar formation can cause, as you could probably try to imagine, it's going to cause narrowing of your esophageal tube. And as that epithelial tissue changes, we can end up with what's called Barrett's esophagus. This is where the normal esophageal epithelial tissue gets replaced by cells that look like gastric epithelial tissue. So it's almost like the esophagus says, okay, we've got to become a stomach, become just like the stomach cells, because we can't, our current state, we can't handle this acid. And we've talked about that in the past being called metaplasia, where we have a change in cell type as an adaptation. And so I'd like you to make note that normally what we see in the esophagus is a stratified squamous epithelial tissue. Stratified squamous epithelial tissue, which is a tissue it is considered a tough tissue in terms of, let's say you swallow a cracker, you chew a cracker and you don't swallow it properly and there's rough edges. It's meant to deal with that, but it's not designed to deal with acidity. And so what we see happening then is the esophagus starts to resemble the stomach in the areas that are affected by the acid. And as we know, when we start seeing changes in cell type, and if there's the occurrence of dysplasia over time where it's becoming abnormal, then it could turn to cancer. So there are many causes of GERD, and what we've spoken about today is a hiatal hernia as a cause of GERD. And in any case of chronic reflux, it's important to try to address the underlying cause when possible. But there is some management that can be done by the patients themselves in order to have some relief. In order to manage these conditions, doctors will oftentimes suggest smaller, more frequent meals in order to prevent overextension of the stomach, which would otherwise cause reflux of contents into the esophagus. And to sleep with the head elevated to keep what's in the stomach, so using gravity to assist. Otherwise, the pain of the acid can really keep the person awake at night, prevent them from sleeping properly, which will cause additional problems to occur. And also not eating right before bed, stopping at least a couple hours before going to bed, can also make a difference. And one more comment to make about GERD and the effects that it can have on the esophagus. Let's say somebody does develop Barrett's esophagus. We know back from back to the start of the term when we spoke about adaptation, that if we remove the inducing stimulus, then the cells can return to normal, to a normal healthy cell. But you need to address the cause of the GERD in order for the cells to no longer be exposed to the acid and begin healing. And this is not to say that everyone that experiences acid reflux is going to end up developing cancer. That's not true at all. Many people experience reflux, but it's the chronic nature that's more of a concern. All right, let's look now at the stomach, reminding you of the purpose. The main purpose is mechanical digestion, or that's the main function. We typically don't chew our food enough, so foods can spend anywhere between 30 and 60 minutes in our stomach being churned and really pulverized into smaller pieces. Acid and pepsin are going to be secreted by the stomach in order to break down and denature proteins, and the acid is going to kill any pathogens that are present. Food will stay here until it's ready to enter the small intestine. So the stomach really does, in addition to being a form of mechanical digestion, it really is a reservoir for food until it's ready to exit the stomach and enter the small intestine. Now, can a person live without a stomach? The answer is yes. In some cases of, for example, stomach cancer, where part or all of the stomach needs to be removed because of cancer or some other condition, then a person can still survive. In other cases, people need or want to lose a substantial amount of weight, and so they can have what's called gastric bypass surgery, where the stomach is left in place, as we can see in this example. But what ends up happening is the esophagus is pretty much connected directly to part of your small intestine, bypassing the duodenum. Remember that the duodenum is the first part, and then we have the jejunum and then the ileum when we're talking about the small intestine. So food goes then pretty much straight from the esophagus into the small intestine while the stomach remains in place. Another type of surgery done for weight loss is called a lap band surgery, where pretty much a giant rubber band is placed on the stomach, constricting the stomach so that it almost shrinks the size of the stomach, so you become full faster. And that's really the principle of both of these procedures, is to make you feel fuller faster while you're eating so that you eat less. But especially with gastric bypass, think about what you're losing, and you weigh pros and cons, of course, but you're going to be losing some of the effects of the stomach. We just spoke about how it's a big component of mechanical digestion, and that it also kills off pathogens because of the acidic nature. The first part of the small intestine is where a lot of nutrients are going to be absorbed, so we can lose the extent to which we normally absorb nutrients. And also, the stomach is going to, we know, be a reservoir for food, so it's going to hold on to food and really disperse it into the duodenum at a controlled rate, so we're not overwhelming our small intestine with all the food that's present within our stomach. But if we lose our stomach, the movement by which food moves through is much faster, which leads me then to talk about a condition called dumping syndrome, which can develop after somebody has had surgery to remove all or part of their stomach. Now, dumping syndrome can occur anytime food moves, or we can say is dumped very quickly from your stomach into your small intestine, really just moving through too quickly before being properly digested. And when it comes to gastric bypass surgery, food is getting dumped directly from this very tiny leftover stomach pouch. So really from your esophagus, through this little tiny stomach pouch right into part of your small intestine without properly being broken down and digested. In this case, it can cause some clinical manifestations such as abdominal cramps and diarrhea, and this can occur anywhere between 10 and 30 minutes after eating, but it can also occur hours later as well. Now, generally, to help prevent dumping syndrome, a diet has to be changed and controlled, and obviously chewing your food properly and maybe even having smaller meals to avoid this because it can cause a lot of problems. Even though a person can live without a stomach, there are going to be problems that they have to live with. We spoke about dumping syndrome already, but there's also a condition called alkaline reflux gastritis or alkaline reflux esophagitis. In both cases, it's inflammation, so inflammation of the stomach and inflammation of the esophagus. Now, what this condition refers to, because the esophagus can be connected directly to the small intestine, let's say somebody has stomach cancer, their stomach has to be removed, and so the esophagus is connected directly to the small intestine. What this can do is cause some of the products that are normally supposed to remain within the small intestine, it can cause them to move upward where they're not supposed to be within the esophagus. Remembering back to the start of today's lecture when I had mentioned that the small intestine is going to receive bile from the gallbladder. The small intestine also produces an alkaline mucus, which is a very different substance than what was produced by the stomach. And so this alkaline mucus can migrate upwards into the esophagus. And alkaline reflux can have a similar effect on the esophagus as acid reflux does. Now that was really referring to a case where somebody had their stomach removed and the small intestine was connected directly to the esophagus, which can lead to that alkaline reflux esophagitis. But in the case of somebody who had gastric bypass surgery where they left a remnant, very small part of the stomach, they can end up with alkaline reflux gastritis. So we can see that here. Here's a remnant of the stomach, so a little small gastric pouch. And so substances that should normally remain here can end up being in the stomach and causing inflammation in the stomach. So what we've done with surgery such as this or removing the stomach is we've just changed the way things are normally supposed to work, which will inevitably have negative side effects. Weight loss is a common side effect, which is the purpose of having gastric bypass surgery, but can also occur unintentionally if somebody has to have their stomach removed due to, for example, cancer. And the reason for the weight loss has to do with inadequate caloric intake. Because you feel fuller faster, you're less likely to eat as much. Dumping syndrome can also lead to weight loss and reduced digestive processes. If you're not properly breaking down and absorbing food, it's less calories that your body's actually consuming and absorbing. Anemia is another important component to consider when it comes to removal of all or part of the stomach. And it's for a few different reasons. There are different types of anemia that exist, and common ones that we'll talk about later in this course include deficiency of B12, deficiency of folate, and deficiency of iron, which is not listed here. Now, the reason for the anemia or the deficiency is partly because of poor absorption and just changing up the way that the digestive tract is normally supposed to function, but also because of maybe inadequate intake, as we spoke about before, just reduced appetite. Another reason that's an important consideration is that intrinsic factor is a substance that's produced by your stomach. And so if you don't have a stomach or you don't have much of a stomach, then intrinsic factor isn't produced. And intrinsic factor is a variable that contributes to our ability to absorb vitamin B12. And if we're not producing intrinsic factor, we can't absorb B12 quite as well. Our final topic today is looking at diverticular disease of the colon. So now we're looking at the large intestine. In diverticular disease, there are the formation of these outpouches. So we're looking here, this is the lumen of the colon, and there are these outpouches that you can see here. Outpouches of the mucosa. So they look sort of like these slit-like openings within the mucous membrane where the bowel is now not continuous as it was. So we'll talk next about a few terms that are relevant with diverticular disease. The first is diverticula. The diverticula are these outpouchings. And so they're sometimes called herniations of the mucus because the mucous membrane is moving away from where it's normally supposed to be. And it's moving right through the muscle layers. This is an example of the sigmoid colon. So the end part of the large intestine. Diverticulosis, however, osis means condition. So this is an asymptomatic version of diverticular disease. So what this means is that if somebody has the presence of diverticula, so these are witnessed on, say, a colonoscopy, but they don't have any symptoms that correspond with it, it is considered to be diverticulosis. The person has a condition where they have diverticuli present. And they may have found these diverticuli just incidentally during a routine colonoscopy. Now, diverticulitis, itis referring to inflammation, is inflammation of the diverticula. So the person has a condition, and now these diverticula have become inflamed. The inflammation is due to infection, so you can get substances trapped within these outpouchings that can lead to the development of an infection and inflammation. If it gets worse, they can actually rupture and they can cause peritonitis. Remember, the peritoneum is sort of the area that's in between all of your organs in your abdomen. And so if you have substances fecal matter that should remain within the large intestine, and now the substances are able to escape through these ruptured outpouchings, then it can infect all throughout the abdomen, and it can be quite a disaster to clean up surgically. Diverticulitis used to be thought of as being a disease in the elderly, but it's seen a lot more now in people who eat a lot of refined foods, also referred to as low residue diets. And what a low residue diet does is it reduces your overall fecal bulk. And so this will then cause the diameter of the colon to reduce in size. And so if all of a sudden there's an increase now in pressure within the lumen of the colon, it can increase enough to rupture these diverticuli. And this image shows you a different view of what those outpouchings look like with diverticulosis. Okay, that's the end of today's lecture. Thanks so much for your time. Bye for now.